Good afternoon, respected teachers and my dear co-PGs. Today I am here to present a seminar on differential diagnosis of pericoronal radiolucency. My contents are introduction, pericoronal space, dentigerous cyst, unicystic amyloblastoma, adenomatoid odontogenic tumor, calcifying odontogenic cyst, amyloblastic fibroma, some rarities and the reference. Now, what is pericoronal radiolucency? Pericoronal radiolucency are common radiographic findings encountered in general dental practice. They may represent a normal or enlarged dental follicle that requires no intervention. Alternatively, they may represent a pathological entity that requires appropriate management and histological interpretation. The pericoronal space which is greater than 2.5 mm in an IOPA and greater than 3 mm in an OPG should be regarded suspicious. The most common of all the pericoronal radiolucency associated with unerupted tooth is the dentigerous cyst, and these lesions may expand or enlarge considerably if allowed to develop unchecked and have potential for the malignant transformation. Now, what is pericoronal space? Pericoronal space is a normal thing. The crown of an unerupted teeth are normally surrounded by a dental follicle, a soft tissue remnant on the enamel organ that is frequently referred to as the reduced enamel epithelium. The dental follicle with increased number of monocytes and osteoclast is necessary for the tooth eruption. Microscopically, when we see this, we see soft myxomatous to dense collagenous fibrous tissue containing nest or cords of odontogenic epithelium are seen. But when we see this radiographically, we see a homogeneous radiolucent halo with a thin outer radioopaque border representing contact bone continuous with the lamina dura. It merges with the perial space and varies in breadth because of various thickness of the follicles and accumulation of the fluid present between the capsule of the reduced enamel epithelium and the crown of the tooth. Now, there are various guidelines that we can differentiate between the normal and the abnormal follicle. When there is a follicular radiolucency and it has been asymptomatic and it is approximately of 2.5 cm in diameter with a surrounding cortical plate which is poorly defined, then there is a strongly suggests any pathosis. But when the width is 2.5 mm and there is evidence of fluid collection within the follicle, in 80% of cases we can suspect that there is some pathosis, but the later is not proved useful for evaluating upper canines, because in upper canines the follicular space is usually larger than any other teeth. Now, these are the differential diagnosis. Adenomatoid odontogenic tumor, this takes place mostly in the anterior region of the jaw. Calcifying odontogenic cyst, it shows radioopaque foci in it, but the pericoronal space has completely radiolucency. In dentigerous cyst, we see in routine radiograph, after every 6 months we carry out routine radiograph and we see whether the teeth is erupting or not, and then we can conclude that whether it is a normal follicular space or it is a dentigerous cyst. Now, how can we manage it? The absence of clinical symptoms. In the absence of clinical symptoms, we take radiograph after every 6 months until the eruption is delayed or tooth is displaced or tooth erupts. So, if the eruption is delayed after taking radiograph for every 6 months, then we can suspect and then we can conclude that that can be a dentigerous cyst, and then we can go for further surgeries. Now, what is a dentigerous cyst? It is also known as pericoronal cyst or follicular cyst, and it is the second most common odontogenic cyst after radicular cyst, which and it is the most common pathological pericoronal radiolucency. It is the commonest among the pericoronal radiolucency and the second most common after radicular cyst. Now, it is associated with the crowns of the unerupted teeth or developing teeth or sometimes supernumerary teeth. It is a slowly growing cyst with markedly thin cortical plates. Now, it has a lumen line lined with epithelium derived from the enamel organ or any other remnants of the dental lamina. Its highest incidence are seen in the second and the third decades, and 5 to 6% are associated with any unerupted supernumerary teeth, and 90% is associated with maxillary mesiodens. It may also lead to malignant transformation and may form various varieties like mural ameloblastoma and mucoepidermoid carcinoma. When we see it radiographically, we see a well-defined radiolucency with sclerotic border at the cemento-enamel junction, but in case of infected cyst, there is absence of the sclerotic border. It can be either solitary or single and multiple. This is a PA view of the dentigerous cyst shown in the right side. Now, the most commonly affected teeth that are unerupted or that usually remains unerupted is the mandibular third molar, maxillary canines, mandibular premolars and maxillary third molar, and everything it is in sequence. They vary greatly in size, less than 2 cm to massive expansion of jaws, and they may cause the expansion of jaws as well as the roots of the jaw disperse or diverge. But on palpation, we feel a rubbery, fluctuant and non-emptyable mass. Now, when we aspirate this, we see a straw colored thin liquid along with cholesterol crystals when rotated in strong light in different angulation. Only the first and the only clinical sign that is seen is the delayed eruption of cyst. The cyst is usually painful when compresses sensory nerves and can be referred to any part of the face. Sometimes the patient complains of headache. Now, dentigerous cyst, eruption cyst is not a different type of cyst. It is a form of dentigerous cyst because it usually occurs in the unerupted tooth or the supernumerary tooth. Now, these are some differential diagnoses by which we can differentiate between the dentigerous cyst and the other pericoronal radiolucency. First is the adenomatoid odontogenic tumor. It usually happens to be in the maxillary anterior region. Calcifying epithelial odontogenic tumor, it has an evidence of calcification, but the dentigerous cyst is always radiolucent. Ameloblastic fibroma, it is usually multilocular. Ameloblastoma is also multilocular. Radicular cyst has a history of carious tooth usually. So, by all this we can differentiate between dentigerous cyst and all this pericoronal radiolucency. Now, how can we manage this? The surgical excision of smaller lesions can be done. Also, marsupialization can be done, which is a treatment for the cyst. Here, the entire cyst has not to means the entire cyst is not necessary to be taken out. Just a small window is made in the cystic wall, and the cystic or fluid is taken out. And then also we can perform elucidation with marsupialization in cases of larger cysts like dentigerous cyst. So, these are the management. Now, what is ameloblastoma? It is also known as adamantinoma or multilocular cyst. Now, it is the most common true neoplasm of odontogenic origin, which is usually unicentric, non-functional, intermittent in growth, locally invasive, anatomically benign and clinically persistent. It is an aggressive type of neoplasm derived from the remnants of the dental lamina and dental organ. It may be intraosseous or extraosseous or unicystic or multicystic. Now, one variant of this ameloblastoma comes under this pericoronal radiolucency, and this is the unicystic ameloblastoma, which is also known as mural ameloblastoma, and it forms from the wall of the dentigerous cyst. Now, this is the second most frequently occurring pathological pericoronal radiolucency after dentigerous cyst. It represents approximately 5% of all the ameloblastoma. There is no gender predilection. It commonly happens to take place in the second decade, and the mandible is more commonly affected. There are other types of cysts which are associated with this: the residual cyst, the radicular cyst, the globulomaxillary cyst and primordial cyst. Residual cyst takes place when there is a remaining of some, or after the tooth falls out, or the remaining portion. In that case, a residual cyst happens to take place. In radicular cyst, what happens? There is any history of any non-vital tooth or any carious tooth. Globulomaxillary cyst is a cyst that happens to be mostly found in the in between the lateral incisor and the canine region, and it gives a pear shaped look in the radiographs. Primordial cyst is a primitive cyst and it happens to takes place in an unerupted tooth like the dentigerous cyst. Now these are some features of the unicystic ameloblastoma. It is asymptomatic and remains undetected until seen on a routine radiograph. It is very slow growing and usually slight non-tender swelling as a result of the expansion of the cortical plates. On palpation, we might feel a hard and a bony, sometimes fluctuant cystic spaces are felt. Now this is a pathological mechanism for the evaluation of unicystic ameloblastoma. The reduced enamel epithelium associated with the developing tooth undergoes ameloblastic changes with subsequent cystic transformation. They arise in dentigerous or other type of odontogenic cyst in which the neoplastic ameloblastic epithelium is preceded temporarily by a non-neoplastic stratified squamous lining. Solid ameloblastoma undergoing cystic degeneration of ameloblastic islands with subsequent fusion of multiple microcysts, and then it forms into a unicystic lesion. Now radiographically, when we see this unicystic ameloblastoma, it looks like a localized thinning and haziness of the hyperostotic radioopaque rim of the pericoronal radiolucency. We can easily make out this structure in the mandible, right side of the mandible. Now what are the differential diagnosis? By dentigerous cyst, which is associated with always with an impacted tooth. Radicular cyst, which is associated with a non-vital tooth or a carious tooth. Management, we can do it by the enucleation of the cyst. Enucleation of the cyst is the complete removal of the cyst and the cystic lining sometimes, and we have to take care properly not to because the cystic cavity is very thin and it is very sensitive, so we have to completely remove the bone first, and then we have to completely take out the cyst along with the cystic lining, and then we can first of all we have to remove the bone and then we can take out all these things. Also we can do curettage of bone, in which we will take all the epithelial tissues associated with that structure, so that it will prevent the recurrences of the cyst. Any cystic fluid left can recur the cyst. Now adenomatoid odontogenic tumor, which is also known as adenoameloblastoma. It is an uncommon, benign and non-invasive which makes up approximately 3% of all the odontogenic tumors. It has an unknown etiology and thought to rise from residual odontogenic epithelium. It is very slow growing tumor and does not infiltrate the bone, and it is inclined to displace the teeth rather than the tooth resorption. It displaces the teeth roots of the adjacent tooth. Usually it happens to occur in the anterior part and mostly maxilla. It might be considered as an hematoma of the residual or odontogenic epithelium. When we see about the male and female predilection, it is of 1:2 ratio. It is mostly common in the second decade of life, but happens to be in the third and fourth decade also. The most common side, as I have already said, is the anterior portion of the jaw in 90% of cases. Maxilla and mandible, the ratio is 1.5:1, but some books they have they suggest it 10:1 ratio is also found, but anyhow the maxilla is more affected than the mandible here. The unerupted tooth associated are maxillary canine region, lateral incisor, premolar, mandibular premolar. These are all in sequence. Now 70% of the tumor is associated with unerupted teeth or wall of the dentigerous cyst, and 27% is not associated with teeth. It is usually asymptomatic, painless, small, sessile, and it is a gingival colored mass. When we see it radiographically, the arrow suggests the region of the AOT, that is adenomatoid odontogenic tumor. It is completely radiolucent with smooth corticated border, but sometimes sclerotic, and it mimics a dentigerous cyst in growth pattern and appearances. But here the dentigerous cyst we can make out with the location. Here it happens only with the anterior region. Dentigerous cyst mostly happens to be in the mandibular third molar region, most preferred site. Here also we can manage by enucleation of the cyst, because these are smaller cysts and it can be enucleated. Differential diagnosis. Odontogenic keratocyst, this happens to takes place in the posterior region, but this is a anterior cyst. Calcified odontogenic cyst, it is an old age cyst. Dentigerous cyst, again as I said, it is a posterior cyst, happens to be takes place in the mandibular posterior region. Now calcifying odontogenic cyst or tumor, it is a rare, well circumscribed, solid or cystic condition which represents a heterogeneous group of lesions exhibiting a wide variety of clinico-pathological and behavioral features. It is a slow growing asymptomatic condition that occurs with equal frequency in the maxilla and the mandible with no gender predilection, and 2% to 4.7% of all the odontogenic tumors accounts and comes under this type of tumor. Now it can be classified into cystic lesions and solid neoplastic lesions. When viewed under microscope, they are usually low columnar or cuboidal cells with dark nuclei, and above that layer or above the basal layer, the cells are irregular that surrounds the nest or sheets of large epithelial ghost cells filled with atypical appearing keratin pigments. When we see this in radiograph, we initially see complete radiolucency, and later on we can see or we can suspect some scattered distinct radio-opaque foci. The border can be smooth, well defined, or irregular and ill defined, and it can be unilocular or multilocular. Here the differential diagnosis are odontoma. Odontoma, it has a radiolucent periphery. Radiolucent periphery is seen. In cases of adenomatous odontogenic tumor, again maxillary anterior is seen. It is seen in maxillary anterior region. Dentigerous cyst also, it is completely radiolucent, and thus we can differentiate between calcifying odontogenic tumor. Here the management is the same, enucleation of the cyst to be done because of the size is smaller. Now amyloblastic fibroma. Amyloblastic fibroma, it is a mixed odontogenic tumor containing nest and strands of odontogenic and amyloblastic epithelium in a primitive dental papilla like connective tissue. It is characterized by a neoplastic proliferation of both the epithelial and the mesenchymal tissue without the formation of enamel and dentine. It is not always associated with unerupted teeth. It is not frequently associated. It has a common age group of second decade. Almost everything, all the pericoronal radiolucent cysts are mostly in the second decade, and mandible is more affected here. It is slow growing, and expansion of the cortex or expansion of the bone takes place, but it does not invade the bone. Here the recurrence rate is 18%. Radiographically when we see pericoronal radiolucency with usually smooth border. We find out unilocular or multilocular cyst, and which is not associated with unerupted tooth, may show cortical expansion and may spread the roots of the adjacent teeth or diverge the roots. Again the management is, we can do it by enucleation of the cyst, because apart from the dentigerous cyst, rest all the cysts can be manageable and they are the smallest size. So we can easily enucleate the cyst rather than marsupialization. Now these are some rarities, these are some rare variants of pericoronal radiolucency. Amyloblastic amyloblastic variants like unicystic amyloblastoma, calcifying epithelial odontogenic tumor, this is environmental primordial cyst, Ewing sarcoma, extrafollicular dentigerous cyst, follicular primordial cyst, Langerhans cell disease, malignant teratoma, paradental cyst, pseudotumor of hemophilia, odontogenic carcinoma, odontogenic fibroma, odontogenic keratocyst, odontogenic myxoma, odontoma in pericoronal location, ossifying fibroma, salivary glands tumors, central, squamous cell carcinoma, squamous odontogenic tumor. These all are a rare varieties of pericoronal radiolucency seen, and the most common are described earlier. Now these are the differential diagnosis of the pericoronal radiolucencies. In cases of unicystic amyloblastoma, they have a specific distinct feature in which we can differentiate between the other pericoronal radiolucencies. Like unicystic amyloblastoma, it is the most preferred site is the mandibular third molar, and also it is asymptomatic, and there is usually it happens to takes place in an unerupted tooth, but sometimes it is not necessary to takes place to happen in an unerupted tooth. In cases of odontoma and other aminoblastic variants, we see the supracoronal position in close proximity to the occlusal surface of the unerupted tooth. In cases of calcifying odontogenic cyst, we see it is asymptomatic, but we see radiolucent foci appear in the later stage. Radioopaque foci appear in the later stage. Initially, we see radiolucency, complete radiolucency. In cases of amyloblastic fibroma, the mandible is 4 times common and happens to takes place rather than the maxilla, the amyloblastic fibroma. In cases of adenomatoid odontogenic tumor, it always in 90% of cases affects the anterior region of the jaw. The follicular primordial cyst, rather than the environmental primordial cyst, it happens to be in the it happens to takes place in the cystic lining of the jaw, of the neck of the tooth, means the crown of the tooth is involved. The cystic lining arises from the crown of the tooth, and thus we can differentiate from all the pericoronal radiolucency. Now, this is a brief table which shows the different pericoronal radiolucencies, and it can be differentiated in which it can be differentiated on the basis of gender, age, and the areas which is most frequently, in which most frequently it is seen, the signs and symptoms and the recurrences. Follicular spaces, there is no age for that, and that is not a pathology, but that is a common phenomena. Impacted tooth, it is very much similar in male and female, and it is usually seen in over 18 years of age, and most frequently the third molar is affected, and there is delayed eruption of tooth, but recurrences is seen, recurs as cyst or amyloblastoma sometimes. In cases of dentigerous cyst, also the age affected is over 18 years of age, and mandibular third molar is affected, and also here also delayed eruption of teeth suggests there can be a dentigerous cyst which we can make out after taking radiograph in every 6 months, and recurrence it recurs as a cyst which is known as dentigerous cyst or amyloblastoma, unicystic amyloblastoma. Now, in cases of unicystic amyloblastoma, the male and female predilections is the same. 85% of this occurs under the age of 30, and also the main frequently preferred site is mandibular third molar. Here we see delayed eruption of tooth, and there is swelling, but there can be asymmetry because of the cortical expansion, and recurrence rate is very rare, occasional. In cases of amyloblastoma, male and female predilection, no male and female predilection. Average age is almost 38, means like third and fourth decade. Most preferred and frequently site is mandibular third molar, and the signs and symptoms are delayed eruption of tooth, and swelling can be seen, and the recurrence can be significant. In cases of adenomatoid odontogenic tumor, the female ratio is more, is twice that of the male one, and its age that is occurs is 10 to 21 years and average 16 years. Frequently maxillary canine, because as I have already said, it happens to takes place in the anterior region, mostly maxillary. Signs and symptoms are delayed eruption of the tooth, swelling, asymmetry is seen here, recurrence is unusual. Amyloblastic fibromas, here also male and female predilection is not shared. 70% happens to be under the age of 20. Most frequently site is mandibular molars and premolars. Signs are delayed eruption of tooth, advanced swelling, asymmetry, and recurrence is very much unusual. This was a brief discussion about all the radiolucencies discussed earlier. These are my references. The tumor that contains cyst is the keratocystic tumor that contains fluid in it. And adenomatoid also, they have Adenomatoid tumor also contains fluid in it. So, sir, I'm unaware of the answer and I'll find it out